This lecture starts with acute phase of burn injury, chapter 26, page 497. So the acute phase of the burn injury begins about 36 to 48 hours after injury when the fluid shift resolves and lasts until wound closure is complete. As you can see on the slide, care is directed toward continued assessment and maintenance of cardiovascular and respiratory systems, continued assessments and maintenance of GI, nutritional status, burn wound control, pain control, and psychosocial interventions. Under cardiopulmonary assessment in the acute phase of burn injury, the priority nursing interventions are to assess the cardiovascular and respiratory system, to maintain these systems, and to identify or prevent complications. Complications could include pneumonia, and the patient is at risk for infection and sepsis, which affect cardiovascular function. Under neuroendocrine assessment, there's an increased metabolic demand placed on the body after severe burn injury, which can severely deplete nutrition stores. We want to weigh the patient daily without dressing or splints and compare the weight with his or her pre-burn dry weight. A 2% loss of body weight indicates a mild deficit. A 10% or more weight loss requires evaluation and modification of calorie intake. Immune assessment. The patient with a burn injury is at risk for infection because of open wounds and reduced immune function. Burn wound sepsis is a serious complication of a burn injury, and infection is the leading cause of death during the acute phase of recovery. We want to monitor for signs and symptoms of infection and enforce meticulous hand washing by all care personnel. You have a yellow box on 498 to use aseptic technique in caring for wounds and during invasive monitoring to prevent infection. Under musculoskeletal assessment, patients with burn injury are at risk for musculoskeletal and mobility problems as a result from other injuries, immobility, the healing process, and treatment. We want to assess active and passive range of motion for all joints, including the neck, and given special attention to joints in the burn area. Ranges and limitations are documented for future reference. You want to review table 26.5 on page 598 for indicators of local and systemic infection, and then also table 26.6, indication of sepsis caused by different organisms. The priority collaborative problems for patients with burn injuries greater than 25% total body surface area in the acute phase of recovery include wound care management, prevention of infection, weight loss, decreased mobility, and decreased self-esteem. So we're going to start talking about wound care management. With appropriate intervention, the burn patient is expected to have no wound extension and have wounds heal. Under non-surgical management, non-surgical burn wound management involves removing exudates and necrotic tissue, cleaning the area, stimulating granulation and revascularization, and applying dressings. Restoring skin integrity starts with removal of eschar and other cellular debris from the burn wound. The removal is called debridement and can be performed non-surgically through mechanical or enzyme actions. The purpose is to prepare the wound for grafting and wound closure by a natural process. Priority nursing interventions include assessing the wound, providing wound care, and preventing infection and other complications. Mechanical debridement, debrided and cleaned 1 or 2 times each day during hydrotherapy. Hydrotherapy is performed by showering the patient on a special shower table or washing only small areas of the wound at the bedside. Immersion of patients into a tub or whirlpool is no longer performed because it increases the risk of infection. Nurses and skilled technicians use forceps and scissors to remove loose dead tissue during hydrotherapy. Most burn units, small blisters are left intact, but large blisters are opened and cleansed. Enzymatic debridement. Enzymatic debridement can occur naturally by autolysis or artificially by the application of exogenous agents. Autolysis is the disintegration of tissue by the action of the patient's own cellular enzymes. This process is seldom used alone because it takes a long time, leading to prolonged hospitalization and increased risk for infection. Topical enzyme agents such as collagenase are used for rapid wound debridement. When these agents are applied to the burn wound in a once-a-day dressing change, the enzymes digest collagen and the necrotic tissue. For dressing the burn wound, after burn wounds have been cleaned, debrided, topical antibiotics are reapplied to prevent infection. Standard wound dressings are multiple layers of gauze applied over topical agents. The gauze layers are held in place with a roller-type gauze bandage applied in a distal to proximal direction or with circular net fabrics. Dressings are generally changed and reapplied every 12 to 24 hours. Biologic dressings. These dressings are skin or membranes obtained from human tissue donors or animals. When applied over open wounds, a biological dressing adheres and promotes healing and prepares the wound for permanent skin graft coverage. Homografts are human skin. Disadvantages to using homografts are high costs and the risk for transmitting blood-borne infection. Heterografts are skins obtained from another species, such as pig skin. It's the most common heterograph and is compatible with human skin. Pig skin is assessed daily for adherence and need for replacement. Cultured skin can be grown from a small specimen of epidermal cells from unburned areas of the patient's body, and the cell sheets can be grafted onto the patient to generate permanent skin surface. It is a long and costly process, and the cell sheets are usually very fragile. Artificial skin is applied to clean, excised wound surface. Fibroblasts move into the collagen part and create a structure similar to normal dermis. The artificial dermis slowly dissolves and is replaced with blood cells, blood vessels, and connective tissue. The neodermis, so there'd be neo being new dermis, supports a standard autograft placed over it when the celastic layer is removed. Biosynthetic wound dressing is a combination of biosynthetic and synthetic materials. Synthetic dressings are made of solid silicone and plastic membranes. They remain in place until they fall off or are removed. They're transparent. The wound can be inspected without removing the dressing. Pain is reduced at the site because these agents also prevent contact of the wound's nerve endings with air. Under surgical management, grafting is used for wound closure when full thickness injuries cannot close and when natural healing would result in the loss of joint function, an unacceptable cosmetic appearance, or a high potential for wound recurrence. Successful skin grafting requires a clean and granulating or freshly excised wound bed. Early grafting reduces the time patients are at risk for infection and sepsis. In surgical excision, the surgeon excises the burn wound usually by removing very thin layers of necrotic burn surface until bleeding tissue is encountered. For wound covering, permanent skin coverage for large, full-thickness injuries occurs by applying an autograft. Skin for an autograft is taken from the patient's own body. After surgery, graft sites are immobilized with bulky cotton pressure dressings for 3 to 5 days to allow vascularization or the take of newly grafted skin. Do not disturb the dressing and encourage elevation and complete rest of the grafted area to allow blood vessels to connect the graft with the wound bed. Any activity that might cause movement of the dressing against the body and separation of the graft from the wound is prohibited. Monitor the graft for indications of failure to vascularize, non-adherence to the wound, or graft necrosis. A dusky color or sharp line of color change suggests inadequate venous or lymphatic drainage. Depending on the graft's location, blood flow to the graft can be monitored using pulse oximetry, laser, Doppler imaging, ultrasound, or transcutaneous oxygen determination. Grafts and donor sites on posterior body surfaces present special problems. For the graft to become fully vascularized, for the donor sites for the graft to become fully vascularized or for the donor site to dry, the patient must be immobilized in a side-lying or prone position for 7 to 10 days. Alternative to this positioning is the use of special low-pressure or air fluidized beds such as Clinitron beds. All right, looks like I'm a little behind in my slides here. We're under minimizing potential for infection on page 501. Burn wound infection occurs through autocontamination, in which the patient's own normal flora overgrows and invades other body areas, and by cross-contamination, in which organisms from other people or environments are transferred to the patient. Signs of infection include foul-smelling discharge, fever, blood cultures and/or wound site colonization, and white blood cell count elevation. Under non-surgical management, priority nursing interventions include using principles for infection control to prevent transmission, providing a safe environment, and monitoring for early detection of infection. Under drug therapy for infection prevention, burn wound conditions promote the growth of Clostridium tetani, and all burn patients are at risk for this deadly infection. We want to make sure that the patient's tetanus shot is up to date and administer the tetanus vaccination if tetanus immunity status is unknown. Topical antimicrobial drugs are used for prevention in all burn wounds. Chart 26-5 lists commonly used topical agents. We've talked about collagenase already. Silver sulfadiazine or Silvadene is frequently used. If you look at the bottom of that chart, you have two drugs with the letters AG behind them, which is the chemical symbol for silver. So if you see a topical agent with AG or silver, know that it's for wound healing. And collagenase we talked about already. So be familiar with those silver topical drugs and collagenase. Then you got some antimicrobial topical drugs also listed there to be familiar with. Systemic antibiotics are used when burn patients have symptoms of an actual infection, including septicemia. Broad spectrum antibiotics are given until cultures and sensitivity status are known. Under providing a safe environment, use of asepsis requires all healthcare personnel to wear gloves during all contact with open wounds. The use of sterile gloves versus clean gloves for routine wound care varies by agency and is a matter of debate. Regarding sterility, change gloves when handling wounds on different areas of the body and between handling old and new dressings. The equipment on burn units are not shared among patients. Disposable items are used as much as possible. Assign any equipment used in daily routines, such as blood pressure cuffs or stethoscope, to each patient for the duration of his or her stay. Daily cleaning of equipment and general housekeeping are essential for infection prevention. Visitors are restricted when the patient is immunosuppressed. Ill people, small children, and other patients should not come into contact with the burn patient. Some burn units recommend that all visitors wear protective clothing in the burn patient's room. Early detection involves careful monitoring of the burn wounds at each dressing change. Examine all wounds for signs of infection, including odor, texture, color changes, purulent drainage, exudate, sloughing, grafts, and/or redness around the edges extending to the non-burned skin. Lab cultures and biopsies are recommended. Biopsies of eschar and granulation tissue are performed routinely to monitor the growth of organisms. Infected burn wounds with colony counts at or near 10 to the 5th or 100,000 colonies per gram of tissue may be life-threatening. Even with antibiotic therapy, surgical excision of the wound may be needed to control these infections. I'm going to have you look at the rest of the section, minimizing weight loss and supporting self-esteem and maintaining mobility amidst on your own. In terms of the rehabilitative phase, that begins with wound closure and ends when the patient achieves his or her highest level of functioning. The emphasis is on psychosocial adjustment of the patient, the prevention of scars and contractures, and the resumption of pre-burn activity, including resuming work, family, and social roles. This phase may take years or even last a lifetime. As you read through the end of the chapter, you see there's a heavy focus on addressing any psychosocial problems that the patient may have when adjusting to any sort of long-term issues they have because of the burn. And in terms of discharge, we want to make sure that we involve all people who will be involved in the patient's home care so that they understand about dressing changes, monitoring for signs and symptoms of infection, and the drug regimens and applications that they might need to use.